guys, welcome to eGurukul DBMCI. On behalf of DBMCI, I really congratulate you for your exams. The results will be soon out, so just be patient and keep focusing on the other works. I have few questions which my students have gave me, and based upon that question, I'm going to give you what could be the best possible answer for the question. Though it seemed this FMG exam was the tough one, a tricky one actually, I should rather say, but most of it we have discussed in the class T&D and also from the question bank. So let's begin. So myself, Dr. Varsha, I'll be taking the biochemistry question from FMG December recall session. So before jumping really into the questions, let me clarify you, these are just based on the recalls what student could have recalled. The options, sometimes I never had any options, so I came up with the options after discussing with them. They might not be in the proper order that was in the exam, but the overall goal for the recall session is to let you know what kind of questions are asked in the exam and really how we really cover those topics and how we address these questions in our app via eGurukul app, how we take these questions in our T&D, in our grand test discussions and from the question bank. Okay, so there was this question that which of the following cycle is not present in the muscle? Okay, glycogenesis, gluconeogenesis, ketosis, lipolysis, right? And this was a very straightforward question, and the answer to this is the ketosis, right? All other cycles such as glycogenesis, gluconeogenesis as well as lipolysis, they both occur, cycle occur both in the muscles as well as in the liver, but ketosis is the one. Okay, and what is ketosis? Ketosis is the formation of the ketone bodies, right? And on the right here on the screen up here, this is the picture screenshot of the book that we have, and that tells you everything about, and we have discussed this several times in the class also, about the ketogenesis, right? These are ketone bodies are the alternate metabolic fuel. Alternate metabolic fuel in the fed state, we have the glucose, but after 2 to 3 hours our blood glucose level goes down, right? So we shift our energy to the glycogen stores, right? But after some up to 24 hours, even glycogen stores are gone. Then we shift to the gluconeogenesis. But gluconeogenesis is like that point of a time our body decides to shift to some of the things to the ketone bodies. So the brain and your heart, they are both like vital organs, right? They should have a constant supply of energy, and that in the prolonged starvation state they shift to the ketone bodies that are generated in the liver, in the skeletal muscles, right? They burn the fat, they use the fat, and from the fat dissociations we have these ketone bodies, and those ketone bodies are used by our vital organs. Heart almost more like in the fed state and also in the starvation, not the prolonged starvation state, it mostly relies on the fat, but in the prolonged starvation state it shifts to the ketone bodies. But ketosis never happens in the muscle. That was the question, and why it never happens. See here, this is how the ketone bodies are generated, right? What are ketone bodies? Ketone bodies are three, mainly acetone, acetoacetate, and beta hydroxy butyrate. Okay, these are your mainly ketone bodies. We know that, right? My students really know that they are water soluble, right? And these are all the transportable form of acetate. Right, and this process takes place in the majorly in the liver, right? by which acetyl coenzyme A is forming the ketone bodies, and that is how it is formed. And there is this enzyme FMGE lyase, which my students very well know is present only in the liver. That's why this process of the ketosis doesn't take place in the muscles, because of the absence of this enzyme. Okay. So now shifting to the next question, how does sun help in the conversion to the active form? So my student couldn't really recall what were the options, but he was kind of gave me a vague idea. So I could figure it out from there. If he's talking about something is being converted from the sun, we are really talking about the vitamin D. Okay, vitamin D is present in our skin also in the form of dehydrocholesterol. We all know that, right? And that upon the exposure of the sunlight in our skin, right, that is converted into activated form. That activated form is the calcitriol, that is 125 DHCC, dihydroxy, at number 1 position. At number 225 position, we have the 2 hydroxyl group. So 125 dihydroxy, then cholecalciferol. This is the activated form of the vitamin D, which we can synthesize in our skin also. We can have it in the diet also. Since it is a fat soluble vitamin, it can lead, excess of it can lead to the toxicity as well. And it is related, if you can really see here, it is related to the patients with the end stage renal diseases. They really have either the deficiency of 1-alpha hydroxylase enzyme. So we have to provide, because 1-alpha hydroxylase enzyme is the key enzyme for the conversion of the 25 hydroxycholecalciferol to the 125 hydroxycholecalciferol, which is again controlled by the parathyroid hormones. In the state of hypocalcemia, parathyroid hormones is triggered, and PTH has a positive influence to trigger this enzyme to synthesize more of a calcitriol, the activated form of the calcitriol. Okay. So I am hoping there were these things. Maybe they have given you the sequence, right, in which they were talking about how really inactivated form of 7-dehydrocholesterol is converted to 125 DHCC. So there are majorly 1 step, 2 step and 3 steps, right? First step is in the skin. Then the cholecalciferol, that is converted, right, is transported via liver, and then in the liver it is converted to 25 hydroxycholecalciferol. Finally, it is taken down to kidney, where it is converted to the 125 dihydroxycholecalciferol. So we should know the tissues where every step is taking place. We should know which intermediates are made where. We should know which enzyme is important. We should know which is the activated form. We should know which is inactivated form, that is in the skin. So I'm hoping that all the options were formed. Maybe there might be big sentences, so that were A, B, C and D options. But now since you have fairly good idea, so you I'm pretty sure if you get this question, you will be able to solve this question in the exams. Okay. Now there was this question, where does short chain fatty acids are absorbed? Very straightforward questions. Short chain fatty acids are absorbed in the large intestine, right? Again, these are the options which my students could remember, right? So short chain fatty acids such as SCFA, such as acetate, propionate, butyrate, right? They are formed by the microbial fermentation, right, in the hindgut, right? And they are effectively absorbed in the large intestine, and that is a part of the notes I have given it out. Okay. Now there was this question that under which of the following conditions the hemoglobin oxygen dissociation curve will shift to left, right? Majorly we talk about right, but here we are talking about the left. And where we have discussed it? We have discussed it from Rappaport-Lubring cycle. This is the portion we are focusing, right? Initially what happens is 1,3-bisphosphoglycerate is converted to 1,3-phosphoglycerate, that is a part of a glycolysis, and from 1,3-bisphospho. Bisphospho means 2 phosphates. Here in this step, 1 phosphate is released and you make 1 ATP, right? That is a normal process in the glycolysis cycle. But what happens in the Rappaport-Lubring shunt? That is shunted towards the formation of 2,3-BPG, right, in the RBCs, but that does not involve any formation of the ATP. Why we talked about it? Here, 2,3-BPG is very high affinity for the hemoglobin, okay? So it binds to the hemoglobin, it keeps the hemoglobin in the tensed state. Tensed state means is the state of the hemoglobin when it is not liking oxygen to be bound to it. It is very tensed, okay? So it keeps away, it decreases the affinity of the oxygen. Like hemoglobin and oxygens are no longer a partner, rather oxygen is being replaced by 2,3-BPG. So it means oxygen is available. So you can very well imagine that in the during the pregnancy, fetus also needs oxygen from the mother. That time 2,3-BPG levels are higher. When we go to the elevated heights, oxygen is less, oxygen is available. Even that time our body like makes more of 2,3-BPG, right? And this is the chart we have discussed many times in the class also. When you have less pH, right, that is acidosis condition, DPG or BPG, one and the same thing, is increased, and at elevated temperature, this normal blue color curve shift towards the dotted red one, that is towards the right. But the question asked you about the left, so that is when pH is increased. pH is increased means alkalosis, and you can very well imagine when you are at height, right, you are more of like breathing so fast, and during that time you're like you have the alkalosis in the system also, right? But question was what? Question was about which of the following condition hemoglobin oxygen dissociation curve will shift to the left? Acidosis, no, it is increased pH. In the alkalosis, it shifts towards the left. In anemia, no. In hypoxia, no. In hypoxia, it shifts towards the right. In decrease in body temperature, yes, it shifts towards the left, whereas increase in body temperature will take it towards the right, right? This is the one we have discussed many times. I'm going to zoom in again for those who are listening this for first time, and also remember this Bohr effect, that is increased in CO2 will decrease the pH, decreasing the pH means the acidity, and that is going to shift the curve towards the right, okay? Let's move to the next question. There was this question, enzyme deficient in galactose metabolism is, right? When we are talking about galactose metabolism, we can think of which enzymes. We can, like, I can think of 2 enzymes, so you should be thinking of 2 enzymes. And if we look back into our notes here, do you see the galactose converting into galactose 1-phosphate, and that galactose 1-phosphate will convert into, will take the UDP and it will finally convert into UDP glucose. And this one, in my handwriting, I have given you something like this, the galactose, okay? So you have the lactose. Lactose is composed of glucose and the galactose by the enzyme lactase, right? And that galactose is taken down, right? And now this galactose will be converted to galactose 1-phosphate, and it is locked inside the cell now, it cannot go out. Now the galactose will be converted into the glucose, because galactose and glucose are just the apimers of each other. But they are not, the process is not as simple that you just take galactose 1-phosphate and you convert it into glucose 1-phosphate. First you have to convert into galactose 1-phosphate so it stays in the room, in the area. Then you will convert this galactose to glucose. And how we do it? It is a little bit not a simple process, but there are steps to it. We take the help of the UDP glucose. This is UDP glucose. UDP glucose and galactose 1-phosphate, they make a deal. Glucose says, bhaiya, give me the phosphate. Galactose says, okay, give me the UDP. Okay, so they both exchange the partners. Galactose के पास phosphate है, ठीक है, UDP के पास glucose है, वो दोनों अपने partners switch कर लेंगे. So galactose will have UDP now, it will go away. UDP glucose will convert into UDP galactose, and the galactose 1-phosphate will convert into glucose 1-phosphate. Now this UDP galactose can be converted into UDP glucose by the epimerase enzyme, right? But here अब क्या है हमारे पास, glucose 1-phosphate है, right, which can be taken down for the further processing, how the body wants to process it depending upon the state of the body, whether they want to make the glucose 6-phosphate and do the glycolysis, or they want to take it down and store it in the form of the glycogen. That will depend upon what kind of a state body is going, whether it is a fed state or the starvation state or the prolonged starvation state. Okay, this kind of a thing. But the enzymes important are, which enzyme has locked galactose? Galactose को galactokinase ने lock किया है. This is important. Another important enzyme is when galactose 1-phosphate conversion हो गया glucose 1-phosphate में. That is done by Gal1P uridyl transferase, and this is the important enzyme. Any of the enzyme missing, that is an hereditary effect. ठीक है, hereditary effect होता है तो उसकी we have the deficiencies related to it, and वो deficiencies are the galactosemia, right? दोनों में से कोई भी enzyme deficient होगा, either the galactokinase or the Gal1P uridyl transferase. Major thing what we will see is galactose level will be high agar galactokinase is deficient, right? Then it will be rerouted towards the lens of eye, jahan galactose will be converted into galactitol by the aldose reductase. So it is like a kind of a cataract kind of a formation is there. So that will lead to the eye issues with us. But not going in detail since you know much about it. Okay. So question is, what can you see the galactokinase here? No. Only this choice, uridyl transferase, is the best choice for us. Why not ADP ribosyl transferase? Where is ADP ribosyl transferase? ADP for the ADP ribosylation, which increases the proteasome activity, and it is a part of the post-translational modification also, where thereby they help in the cell signaling, DNA repair, they participate in the gene regulation and also as well as in the apoptosis. Glucosyl transferase, where do you see glucosyl transferase? Here, to make the natural glycosidic linkage जो हमारे we make, right, that is done by that, and there are few donors who help it. What are those donors? UDP glucose, we have just seen, right, galactose mein, but that is just an helping point, that is like behind the curtains, not in the forefront, it is behind the curtain. So that is why the choice C is not the correct choice. UDP gal, UDP GLACNAC, right, or what do you call it? UDP, what is the full name of this? Okay, go and check it out, Google it. Okay, this is your homework now. So UDP xylose, UDP glucuronic acid, GDP mannose, you have GDP fucose, CMP sialic. All these are the natural helpers to make the glycosidic bonds in the body. And the choice D is not the choice. Why not the choice? It is used in the biosynthesis of the antibiotics. Okay, so that is in vitro we are talking about. We are not talking about anything that is going on in your system, and those antibiotics are carminomycin and denoribinacin. And how you are going to remember it? If you go to the options, what do you see? What is the name of the C? TDP denosamine. Okay, and here antibiotic name is what? Denoribicin. So you can correlate the name कि वो उसके लिए use होगा, not for the galactose. ठीक है? Now there is this question, which of the following would be the drug of choice in the mountain sickness, right? The best pick here is sulfonilamide, that is acetazolamide, that is a carbonic anhydrase 2 inhibitors, and carbonic anhydrase is like what is going there in the mountain sickness. We are suffering from the hypoxia kind of attack because of the low availability of the oxygen. We are going to hyperventilate, that will raise the pH, and we have these buffer system in our body, like the phosphate buffers we have, the carbonic anhydrase buffer we have, and here in this case carbonic anhydrase buffers will be controlled by acetazolamide, which is a sulfonamide, which is a carbonic anhydrase 2 inhibitor in particular. We have so many isoenzymes of carbonic anhydrase. 2 is the one which we want to inhibit with the use of the acetazolamide. The other options, thiazide, furosemide, spironolactone, all those are diuretics. Okay, so here is the one, probably you have seen it several times in the class also. Acetazolamide is here, but we will starting from the left. Okay, what is there in the mountains? You have the low partial pressure of the oxygen. That means ventilation is being increased, right? That is alkalosis is resulting, and to compensate for that alkalosis you have to take the acetazolamide for the mountain sickness, right? And the brand name of acetazolamide is the Dimox, right? It is a standard medical prophylactic agent for the high altitude illness, right? Also effective in high altitude pulmonary edema, also used for the treatment of high altitude cerebral edemas also. Okay, and this is from one of your book. You can very well remember from the pharmacology book. This question is an integrated, actually more towards the pharmacology, but I thought just to let you know, but you can go to your pharmacology teacher, and if you want to like get more detail, he is the best person to help you out more into it. So here are the carbonic anhydrase inhibitor, meaning acetazolamide, it affects here, whereas the loop diuretics, thiazide, potassium sparing diuretics, they act at a different part of your distal convoluted tubules. Okay, and this is in the notes also, what are the adaptations at high altitude, right? More of a physiological notes. There is an increased respiration, respiratory alkalosis, low P50 for hemoglobin, right? Increased rate of glycolysis. There is increased VPG because we want to decrease the affinity for the oxygen so that more oxygen is available for the tissues, right? And then there is increased hemoglobin and the hematocrit. These is what we do. And if you can remember, there is this brown paper, like paper bag respiration also. Whenever you have, let's say, alkalosis, this I'm talking about now the alkalosis. You have the alkalosis in the system. You take the brown paper bag, kagaj ka brown wala paper bag hota hai, you put it on the mouth and then you exhale it and inhale the same exhaled air. That lowers your alkalinity, like lowers the pH down. Yeah, lowers the pH down. Okay, so that is a temporary relief, and you can try it when you are in trouble and you don't have medication. A child presented with low BP has clitoromegaly. Which enzyme deficiency is suspected here? One of the very typical FMG. Let me tell you about this FMG. Most of the questions what I have seen are the integrated questions. I'm talking about the biochemistry part. इतने आसान नहीं थे, but you have to think a lot. बहुत सारा सोचना पड़ेगा और उसके बाद dots को connect करके you could derive the answer कि अच्छा ये हो रहा है. So this is telling you the new approach कि आगे आने वाले time में FMG क्या सोच रहा है. They want you to be more realistic, that there are everything, every system in your body is interconnected, right? So you have to now study in an integrated way, which you are doing it, but in the exams you can see those questions also, that those are not the straightforward questions but the interconnected one. This was one of the very typical questions, right? That is answer to is this 17 alpha hydroxylase deficiency. That is the answer to this question, right? What is this clitoromegaly, right? This is male pseudo hermaphroditism, right? And this is happened because of the 17 alpha hydroxylase deficiency. This enzyme is helping you to make this testosterone, right? And I have picked out a paper for you, right? And I guess this is the best paper who is telling you a lot that the testosterone, okay, so the testosterone is the one who is the culprit. Okay, so androgens are the C19 steroids that originate from the cholesterol, right? And this is steroidogenesis. This is your male pseudo hermaphroditism, right? Because that is happening because of DHEA, right, which converts into A aldosterone, then finally into T testosterone, and based upon कितना percentage deficiency का है उतना percentage you will see in the patient. Okay, and this is from one of very big journal. इससे ज़्यादा clear original journal में भी नहीं था picture, but what we want to see here is the testosterone that we are making. ठीक है, I'm just going to guide you. This is the testosterone. ठीक है, I don't have really like in the original paper this was vague, and this is the best figure I could pulled out for you. And what you have is the enzyme 3 that is helping to make the testosterone. That is problem with the patient. And the number 3 here is 17 beta hydroxy steroid dehydrogenases. Okay, and more detailed discussion, please go and listen to the lecture. Okay, then you can be helped out more. Okay, shifting to the next question, that was question number 8. Deficiency of glucose 6 phosphatase lead to what? What is glucose 6 phosphatase? Where do you see it? Gluconeogenesis में हम इसको देखते हैं, right? And the deficiency of glucose 6 phosphate leads to what? Type 1A glycogen storage disorder. याद है? वोन गर्के डिजीज इज बिकॉज ऑफ ग्लूकोज 6 फॉस्फेटेज डेफिशिएंसी. अब उसमें होता क्या है? कैन यू रिमेंबर? ये हमने देखा है ग्लूकोज 6 फॉस्फेट टू ग्लूकोज, और वो ग्लूकोज 6 फॉस्फेट कहाँ से आ रहा है? ग्लाइकोजन स्टोर से आ रहा है. वी आर डूइंग द ग्लूकोनियोजेनेसिस. सो ग्लाइकोजन टू ग्लूकोज 6 फॉस्फेट, ग्लूकोज 6 फॉस्फेट टू ग्लूकोज, एंड दिस इज डन बाय ग्लूकोज 6 फॉस्फेटेज एंजाइम जो अभी वर्किंग पोजीशन में नहीं है. सो उससे क्या होगा? उससे इसका लेवल बढ़ रहा है, ग्लूकोज 6 फॉस्फेट का लेवल बढ़ रहा है. तो कहाँ करेंगे इसको? ज़्यादा शिफ्ट कर देंगे हम लोग शंट में, हावर हेक्सोज मोनोफॉस्फेट शंट में, उसका लेवल बढ़ जाएगा. व्हाट इज हेक्सोज मोनोफॉस्फेट शंट इज डूइंग? राइबोज 5 फॉस्फेट ज़्यादा बनाता है. उससे क्या होगा? प्यूरिन सिंथेसिस इंक्रीज हो जाएगा. ज़्यादा प्यूरिन सिंथेसिस होगा तो यूरिक एसिड बढ़ जाएगा. यूरिक एसिड बढ़ने से क्या होगा? गाउटी सिम्टम्स यू विल सी. ठीक है, तो दिस इज व्हाट वी सी इन द वोन गर्के डिजीज ऑल्सो. ठीक है, अब ग्लूकोनियोजेनेसिस वेयर इट हैपन्स? इट प्राइमरली हैपन्स इन द किडनी एंड द लिवर. ठीक है, and this is one more. My students have seen it several times. So कहाँ gluconeogenesis होता है? We are talking about brain, liver, kidney, muscle और adipose tissue की हम बात कर रहे हैं. ठीक है, अब इसमें we will start from brain. ब्रेन ने क्या किया? ग्लूकोज लिया, ग्लूकोज 6 फॉस्फेट बनाया, ग्लाइकोलाइसिस किया और एनर्जी जनरेट कर दी. कोई ग्लूकोनियोजेनेसिस नहीं होता है. लिवर में देखते हैं हम. लिवर में डू यू सी ग्लूकोनियोजेनेसिस? ग्लूकोनियोजेनेसिस होता है, राइट? इन किडनी डू यू सी ग्लूकोनियोजेनेसिस? यस, you see gluconeogenesis. In adipose tissues, do you see gluconeogenesis? No, you don't see it. Same is in the muscle. Do you see? There, from the glycogen, you get this, but you don't really do it. You do it, but not majorly. Majorly, you do it in the liver and the kidney. मतलब करेंगे ही करेंगे. हाँ, जब problematic situation हो जाएगी, then दूसरे organs भी compromise करके ready हो जाते हैं. But who does it primarily? Liver and the kidney does it primarily. अब क्या है? अब ग्लूकोज accumulate होगा कि ग्लाइकोजन accumulate होगा? एटलीस्ट ये ऑप्शंस तो क्रॉस आउट है. अब ग्लूकोज ग्लाइकोजन accumulated in liver or the skeletal muscles? Glycogen accumulated in the liver, not in the skeletal muscle. So इतनी सारी चीज़ों को समझ कर then you have to pick the option out. Now there was this question. Patient came with dermatitis, diarrhea, mental retardation. Upon taking history, it was found that he is a strict vegetarian, mainly coming from the maize eater tribe. What is the diagnosis? What do you figure it out? Dermatitis, diarrhea, mental retardation, that is dementia. 3 Ds हो गए? Right, you have 3 Ds or 4 Ds, death, that is the fourth one. That is because of the niacin deficiency. And what is niacin? B3, B12, B9, B1. कौन सा है? B3 is the niacin. What is B12? Cobalamin. What is B9? Folic acid. What is B1? Thiamine deficiency. But we are talking about यहाँ पे niacin. And niacin is one of a typical vitamin. विटामिन के भी एटिपिकल विटामिन है और विटामिन B3 नियासिन भी एटिपिकल विटामिन है, बिकॉज वो बॉडी में सिंथेसाइज नहीं करते. मेनली नियासिन का खास बात इज देयर इज दिस अमाइनो एसिड इन योर बॉडी, ट्रिप्टोफैन, उससे आप नियासिन बना सकते हैं, ठीक है ना. एंड वी नो दैट व्हाट from the notes also 60 milligram tryptophan is converted to 1 milligram of the niacin body. Excess is toxic, right? तो जितना चाहिए उतना बना सकते हैं. That causes the liver damage also. And main thing is 3 Ds, that is pellagra is 3 Ds, diarrhea, dementia and the dermatitis and death if not treated. And what else था? Casals or collar or the necklace region. But अभी तो ऑप्शन में it was easy, you have the niacin, but remember in the Hartnupp's disease and the carcinoid syndrome also they are related to the tryptophan. So tryptophan के deficiency से niacin का deficiency हो सकता है, तब भी pellagra होगा. tryptophan की deficiency की वजह से you have the Hartnup syndrome and the carcinoid syndrome also. इस वजह से भी tryptophan ही नहीं है तो niacin, एक तो niacin ही नहीं है, niacin is not there, you have the pellagra. One thing is precursor, major father जो है niacin का, tryptophan is gone, again you will be having the symptoms of the pellagra, that is Hartnup disease and the carcinoid syndrome. But here the choice, this question was relatively easy, vitamin B3 भी दिया हुआ है, but you can have the Hartnup also, you can have the carcinoid syndrome also, ठीक है. You can you have the book, you can read it through it, what folic acid is doing, right? Folic acid में what you will be having, we will be talking about the tetrahydrofolate, okay, tetrahydrofolate. We don't have the pellagra, but what we have is we have the folate deficiency, we have the folate deficiency. और B9 के साथ folic acid के साथ B12 का deficiency हो जाएगा, तो that will lead to the folate trap. But just the folic acid deficiency is give rise to megaloblastic anemia, right? Risk of colorectal cancer, those taking too much, because nowadays everybody is becoming like you can say the half doctor. They are taking the supplements on their own, thinking okay this is good for us, but we know, right, that excess of everything is bad, and we should be taking, common people should be taking even the vitamins, multivitamins after referring to the doctors. कितना चाहिए, कौन सा चाहिए, कितना अमाउंट में चाहिए, कब खाना चाहिए, कितने इंटरवल पे खाना चाहिए, that what doctors are for. So excess of vitamin, excess of folate especially can cause increases the risk of the colorectal cancer, right? I have studied too, like so many times I have talked about it. And what we have, like a person having folate deficiency will have the megaloblastic anemia, that is on the upper right in your screen, okay, megaloblastic anemia. Here हम pellagra की बात करते हैं, वो तो वैसे ही सीधा पता है कि pellagra, diarrhea, dementia and dermatitis and finally the death if not treated, right? Vitamin B12 में what we have the vitamin B12 का deficiency में pernicious anemia is the most common cause, right? जो vitamin B12 के absorption को hinder करता है, that leads to vitamin B12 deficiency, right? Then उससे क्या होगा? It will lead to the megaloblastic anemia and irreversible generation of the spinal cord, okay? Coming to the next question, which was similar to the previous question, which of the following activities are low in riboflavin deficiency? Riboflavin is your vitamin B12, right? That and vitamin B12 containing enzymes are your flavoproteins, FAD, FMN, right? And what happens is there is a low activity of the glutathione reductase, that is one of the marker, right? Here, remember, deficiency of the riboflavin is identified by the decreased activity of the erythrocyte glutathione reductase, right? So very straightforward, very simple answer for us, okay? Now question number 11 was patient come with delayed wound healing, bleeding gums and also pooling around the eyes were noted. Well, when you have the delayed wound healing, when you have the bleeding gums, best thing is कि हम भैया विटामिन सी deficient है, ascorbic acid को उठा लो, bleeding gums है. But as I always say, wait and watch. What is else is given? Pooling around the eyes. That is mainly किसके लिए वजह से होता है? Vitamin K और vitamin B12 की वजह से होता है. But do you have the option? Definitely we don't have an option. Pooling around the eyes, dark circles हो गए हैं, sags बन गए हैं. That is also because of the vitamin K, B12 and also because of the iron deficiency. They are at the forefront ki inki deficiency you will have all these things. But at the back end there is vitamin C standing who helps in the absorption of iron also. But that option is given. इसके अलावा तो ना तो vitamin K है, ना vitamin B12 है, ना iron है. अगर होता तो vitamin K was the best bet, better than the vitamin C. ठीक है? And this was the comparison chart given to you in the class, like, and we have discussed it. What is the difference? बहुत close difference है. But vitamin K is a fat soluble vitamin. Vitamin C is a water soluble vitamin. Both have the easy bruising and the bleeding. Both have vitamin K have the normal bleeding time, but vitamin C में is the increased bleeding time. Vitamin K में you have increased PT, but vitamin C don't have the increased PT, right? Vitamin K is there is no connective tissue problem. Vitamin C is a connective tissue problem. क्यों? Because the deficiency, there is a problem with the hydroxylation of the proline, like proline and the valine residues while they are making the collagen fibers. वो loosen हो जाता है. Prolyl hydroxylase या lysyl hydroxylase का deficiency है. Hydroxylation is not proper. That is leading to the loose connective tissue. That is giving rise to the bleeding time. And why the enzyme deficiency is causing this? Because those enzymes, both enzymes, they need the vitamin C as helper to work it out, okay? So gum hyperplasia, skeletal deformity, poor wound healing, anemia. So vitamin C for us is the right choice. But when it comes to the pooling around the eyes noted, then the best pick, better than the vitamin C, is the vitamin K. I'm telling you right away, okay? Next question was, a chronic alcoholic is admitted to the hospital. He had drinking issues since 2 decades, more than 20 years. Wow. He's facing lots of health issues. Obviously, होने ही वाले हैं. He's trying to quit alcohol. Okay, he's trying to quit alcohol. Not drinking since 2-3 days. He's being hospitalized with agitation, hallucination, disorientation, global confusion. Nurses recorded high fever, increased blood pressure with diaphoresis, autonomic hyperactivity. All of above are indicative of what? Definitely pancreatitis is not an option. Wernicke encephalopathy, Korsakoff syndrome and delirium tremens. Answer is the D. Why? Because here they are saying he is trying to quit alcohol. Trying to quit alcohol and all the symptoms, agitation, hallucination, disorientation with diaphoresis, autonomic hyperactivity, that all are symptoms of the alcohol withdrawal symptoms. These are alcohol withdrawal symptoms. High fever भी आएगा, आपको blood pressure भी बढ़ेगा. But in the Wernicke's encephalopathy, क्या देखेंगे हम? You will see the ophthalmalgia. You don't have it. Question में दिया ही नहीं हुआ है. In the Korsakoff syndromes, you don't see the autonomic hyperactivity. So that is also not a better choice for us. Best choice is the delirium tremens, okay? And this is from one of the articles from NCBI I have pulled out here for you. Is alcohol, what it does is it affect some of the neurological pathways are affected, right, which includes dopaminergic, serotonergic and the gamma amino butyric acid, that is your GABA, and the glutamate pathways. So when a person is taking alcohol for the prolonged period of time, so these receptors have kind of an almost stable changes in them. But as soon as they don't get something, these receptors don't get triggers from the alcohol because the person is not consuming alcohol, then there are all the symptoms that are your withdrawal symptoms. So you can just really sit and read it properly, right? Read it properly so that you get a better idea, like a story kind of a thing. I can read it out, but the thing is, earlier, since 20 decades, the central nervous system of this patient became habitual of getting the alcohol, right? And suddenly it is not there. So all the symptoms are being seen, And the secondly is the high BP and high temperature is the indicative of the withdrawal system with the hyperactivity of the withdrawal system. Yeah, that's it I want to talk about. And here is from the class that the Wernicke encephalopathy, you have the ataxia nystagmus and ophthalmoplegia, right, which is not given for the patient. Korsakoff's, you have the confabulation and the psychosis, but no high fever, no high BP, no the kind of a hyperactivity, like very anxious. And during the alcohol withdrawal system, I have seen many patients, initially one day is okay, but their urge to have an alcohol, परेशानी होना कि भाई चाहिए ही भैया, चाहिए ही चाहिए, even for the drug abusers also, second day onwards बहुत बढ़ जाते हैं. So from day 2 to day 7, they are like, you need a heck lot of efforts to control them. Best thing is give the sedative, सुला दो उनको. 2 से 7 दिन अगर वो पार, they clear this ना, this phase is like very crucial phase for them कि उनको अल्कोहल चाहिए ही चाहिए, even for drug abusers चाहिए ही चाहिए, right? The best option is to give the sedatives, let them sleep, otherwise havoc create हो जाता है, ठीक है, बहुत मुश्किल हो जाता है, but eventually it is doable, right? That was it. I had this much question. If you have more questions, please do not hesitate me to email me. That was on the first slide, right? You can drop me email. You can also give me the feedback. What kind of questions you expect from me to give you out? If you want to make any changes in the options or the questions, please do so. Write it in the comment box. See you in the class and good luck for your future. Bye.